So I think we're going to, we don't have any case presentations, which leaves us plenty of time for questions and answers and discussion. Dr. Goldberg.
I have two questions. First of all, why do you have, it's nice that you invite your plastic surgeon to learn from you, but what does the plastic surgeon do in this case?
It's a great question. So the question was, why is the plastic surgeon involved? Well, frankly, she got me involved. So I feel that bit of dedication to have her part of the team. Can we harvest a scleral nerve? Yes. But for collegiality, I've chosen not to.
That's fast. But the point is, for someone starting out, all of these things are certainly, within our realm, probably best done by us.
So in the Toronto group, this is actually done by 2 teams of plastic surgeons and 1 cornea surgeon. So there's 3 teams involved. But I agree with you.
The second point I was going to make, I'm so fascinated by Ilya's idea of the, cadaveric nerve grafts. I'm trying to come to grips with how that could work biologically, but it would certainly simplify it. Are you motivated to try the cadaveric grafts?
So there's been a few, the question was, are we motivated to try the cadaveric grafts? And Mike may be a better person to speak onto this because he does it as well. But for us, some of the limitations for that, again, notwithstanding the need to have my plastic surgery colleague involved, is it is quite expensive, and I don't know the exact cost. I mean, I know it's many thousands of dollars. But then additionally, it's actually pretty short. So there's not a very, it's not a very long graft, and the way that we've chosen to do our nerve, our suturing it to the sclera, it simply needs a fair amount of length. So that's been probably the biggest drawback that I can think of. But Mike.
Yeah, I mean, I don't want to suck up all the time on discussing this, but Bob, I think it's a great question. I do like to use the cadaveric nerve graft, and the way I kind of think of it is, what exactly do we think is going on with neurotization? If we're doing a nerve graft, whether it's a scleral nerve graft or a cadaveric nerve graft, and you think it's just a conduit for new nerves to grow through, then a cadaveric nerve graft should work just as well as an autogenous graft. If you think that it's not just new nerves growing through, that you're bringing in neurotrophic factors, then again, it's acting like a conduit. So to me, I haven't been convinced that, and certainly the results, the preliminary results of using the cadaveric nerve graft seem to be very encouraging. They've all worked. We've had really good successes with it. So I'm not sure what advantage, I'd flip that around. I'm not sure what advantage using an autogenous graft is, except for when you need a significant length, because 7 centimeters is the maximum. I think if you're doing ipsilateral nerve graft, that's 7 centimeters is plenty. If you're doing contralateral nerve graft, that's kind of a stretch.
Well, the company probably would make longer ones if we wanted them.
I think it's probably. It's an issue of harvesting, I guess.
One question also, how long are you keeping a tarsorrhaphy in?
So I do a temporary tarsorrhaphy that I keep in for 2 weeks. Now, 2 of my patients have had to require additional tarsorrhaphy, but the majority of them we've just kept in with dissolving sutures over about 2 weeks.
And then another question is, I've heard some chatter from the cornea doctors about some of the newer nerve growth factors that they're using for neurotrophic corneas, and I guess the question is going to be what are going to be the indications for neurotization? What are going to be the indications? Or maybe
and actually, I think
together. Actually,
I actually think the indications are probably the most interesting thing about the people that are doing this. So we have people that are doing it for structural or surgical, indications. We have people that are doing it for post-traumatic or disruption of the long ciliary nerves with retinal surgery or things like that. And then we have people that are doing it also for herpetic disease. My mind has a hard time wrapping around the herpetic disease, but talking with Ilya, it seems to do the job, and so I'm happy about that. I don't know enough about those drugs to know what types of neurotrophic corneal disease would do better with that. And so for my practice, I guess I have to rely on what my cornea colleagues think would be a better indication for it,
right.
But I don't know.
I personally don't have any experience with it, but it seems as if it's something that's getting a lot of...
It is certainly getting a lot of press.
Yeah. But I think it's 2 different things, because with the nerve growth factor, that has been shown to allow corneas to heal but it doesn't improve their corneal sensation.
Right.
It doesn't restore sensation. So I think at the end of the day, it depends on what you're dealing with, and if you're dealing with a true neurotrophic state that is a long-term chronic problem, if you're not improving the sensation, you're really just temporizing them.
I mean, I think my interest would be more whether you could use it with neurotization to see if it would enhance or...
To enhance, right?
Yeah.
Yeah.
Dr. Sobel, do you see bilateral nasolacrimal duct obstruction in patients undergoing chemotherapy? And if so, can you give us some guidance as to which agents those may be and how do you manage that?
Sure. I just had one quick comment of that last discussion. I do know I've had a patient that we're considering neurotization, but we've been looking into drops, and the cost is really one of the biggest challenges. It's $95,000 for the drops for short-term use of it. So that's one of the hurdles right now. In terms of chemotherapies, yes, definitely there have been documented good papers on this. There's one in OPRS 2017 by Dr. Ismaili and colleagues looking at a survey of chemotherapies that cause nasolacrimal duct obstruction. The big ones are 5-FU, docetaxel, mitomycin C, and there's some others. And these can affect all parts of the lacrimal system, from the punctum to the canaliculus to further down in the lacrimal system. So really in these patients, it depends upon how they present. So I've had a mitomycin C patient with punctal stenosis. I've had 5-FU patients with canalicular stenosis. They needed Jones tube. So my management depends upon where the blockage is.
Dr. Mancini, I think this is a good question here. Mitomycin C for endo-DCRs.
So I do use mitomycin on revision cases.
Not for your primary
Not a
case?
primary case. So not for a primary case. I don't think it's needed. But if I go back in on a patient who's failed, and then there's evidence of definite significant scoring, then I do use mitomycin C.
Can you describe how you use it?
Yeah, so I use the typical glaucoma dose that they use. I apply it to a cotton swab. You have to be very careful because one of the big risks is, I mean, anything it touches, it really causes significant problems. So if you touch the septum, you can certainly get a septal perforation. So I'm really careful to keep this just on a cotton swab, place it directly on the ostium that I've created for 2 minutes, and then remove it.
What about engaging your ENT colleagues? Do you ask them to help? Do you consult them for
the
DCR
surgery?
cases?
No.
No. Yeah.
What do you do for patients with really thick bone? Let's say you have that young African-American man who comes in with thick bone. What other instrumentation do you use during your procedure?
Yeah, so the majority of the time, the kerosene will work, but there are patients who have a very thick frontal process that it's actually too wide for the kerosene to actually grasp. So in those cases, I'll often just use an osteotome to remove some bone, or you can use a drill as well, a guarded drill bit. But typically, the kerosene works in the vast majority of cases. The osteotome usually will finish that, and if needed, we used to have a lot of patients come from Fiji and the Pacific Islands, and their frontal process is incredible. And you could break the osteotome even. So those cases, you actually do have to, a lot of times, move to a drill.
I have a question for Dr. Couch. So I think you looked at axon counts, supratrochlear and supraorbital nerves, because we're presumably trying to find a robust donor nerve to coapt the graft into. To me, it seems like the infraorbital nerve is so large and so robust. The axon count is probably 30 times as much as the supraorbital nerve. What are your thoughts on going down there?
So in the right patient that has V2 sensation, certainly I would consider an infraorbital nerve. It is actually so big, in some ways it may, you may not, it's like putting us, because the nerve graft is so small compared to the size of the infraorbital, it actually may be, I don't think it's too big, but it's not going to, it doesn't fit well together.
You're doing end-to-end or end-to-side, though?
End-to-end.
What about, is there an advantage to doing end-to-end as was?
Yeah, so that's heavily debated in nerve grafting surgery literature. But for sensory nerves, the end-to-end seems to have a quicker and more robust reinnervation.
But then you also deal with permanent nerve distribution anesthesia if you're doing end-to-end.
You do, but the literature says that that the overall success rate of the surgery is significantly higher as well.
So here's an interesting question. Maybe we'll just poll the panel here. Endo DCRs, general or sedation?
General.
General?
Yeah, general anesthesia.
100%?
100%, yeah. I mean, this is it can be a bloody surgery, so it's, the patients can't protect their airway, at least in my opinion, adequately to be safe enough.
Rachel?
General.
I do general, but I know Mike does sedation.
Gosh, I'm the outlier. I say I probably do 80% under sedation and 20% general. 95%, Dr. Goldberg, 95% sedation. Well, it just tells you you can skin a cat in a lot of different ways.
So do you pack the throat or anything like that?
So I don't pack the throat. What we do give them using an atomizer, I give them a spray of oxymetazoline and then 2% lidocaine with epi.
Mm-hmm.
I also inject the mucosa right before we start, the nasal mucosa with some lidocaine with epi as well.
Yeah.
And sometimes, I'm not going to say it's a bloodless procedure, but
Right.
no one's aspirated.
Do you do an anterior ethmoid block?
So I do. I block it. I do an anterior ethmoidal block as well, or a periorbital block in the orbit as well. Transcutaneously. And they're pretty, Adam, my fellow, can say, they're pretty light. It's not like they're deep sedation. So I'm not sure they're sedated enough where they lose control of their airway. Dr. Goldberg, do you want to?
Yeah, I'm always a little worried about it, but in 20 years, we haven't had someone aspirate. That doesn't prove that it's completely safe. We do control their airway. I just find the wake up faster. It's less bloody.
I definitely think it's less bloody. Anytime you do lacrimal surgery and it's awake, it's definitely less bloody than a general anesthesia.
Couple more minutes. Okay. Dr. Couch,
Yes.
can you describe the location of your scleral tunnels in relation to the limbus? Or can you, I'll expand on that. Can you just tell us your thinking behind doing scleral tunnels? Because several authors have reported not using any scleral tunnels.
Yeah, so that's actually a good question. So the idea is that you get the nerve to the source that you want it to be in. And so if you can do a partial thickness scleral tunnel, perhaps those axons will be able to penetrate the limbus and reinnervate the cornea in a more successful fashion. I know colleagues that simply will lift the tenons and put the nerves under the tenons, and it seems in my mind that would be a little bit more not as directed of nerve growth. That'd be my concern. We have done one patient that we didn't do scleral tunnels, and they did fine, but we simply did suture it to the limbus nonetheless, and that seems to work as well. But I think, and perhaps the way that you do it with the nerve graft, and not taking it all the way to the limbus, perhaps that may allow you to get away with not using anything greater than 7 centimeters. I don't know. But certainly going to the limbus, I think, makes a lot of sense.
Here's another question that I think might be of interest. What do we use for cautery in endoscopic DCR if bleeding is significant? I personally don't use cautery at all. Yeah, just pack.
That's the ENT approach, is to pack the nose.
It stops bleeding eventually.
So I've actually used the ENT rhinology suction cautery before. There's a suction cautery that comes on a Bovie tip, and it actually works, you know, in somebody that you're actually getting some bleeding, that works pretty well, actually.
Dr. Mancini?
Probably one, so I don't open cautery to start the case, and I'd say maybe 1 in 25 cases I'll have to use cautery. If I do, usually just the Bovie will be fine. If it's significant, the suction Bovie is good. You can use a bayonet bipolar, but most of the time you don't need anything.
I like packing with 4% cocaine because it not only has vasoconstrictive capabilities, but it's very good with anesthetic, and the patients wake up without pain.
I always remember what Rick Anderson used to tell me is like when you have bleeding, when you're doing LACMO surgery, the best way to stop the bleeding is finish up. Because I think a lot of times we're in there manipulating, and the more you touch, the more you are moving things around, the more bleeding you're stirring up. So I tell the fellow, finish up, hurry up. Yes? Do we have any experience with what was that?
Oh, the tranexamic acid.
Yeah.
I have no experience with it, but I did see a paper on using it in surgery. No.
I haven't used it. It makes sense that it would help, but I haven't used it.
You should start a company,
Put some in your Afrin, too.
All right, well, I want to thank everyone for coming and for participating. I think this was a very interesting and lively session. Let me end by saying on corneal neurotization, because I kind of have an interest here. Just in 2019 alone, there have been 13 publications on corneal neurotization, which outnumbers the number of publications for all the years prior to 2019. So I feel like this is a field that is about to, or has already started to explode, and certainly is to the benefit of the patients. This is a transformational procedure that we can offer to patients.
Thank you very much.
Thank you.